Providing the highest quality care to children with complex and chronic conditions is the mission of the world's leading pediatric hospitals. Families put their faith in healthcare providers to diagnose and treat their loved ones, and often save their lives. Astonishing advances over more than a century have helped make this possible.
Well, in order to maintain the standard of excellence, world-class pediatric hospitals need to continue to improve and develop diagnostics, devices, therapeutics, new healthcare IT solutions. But these solutions require money and people.
But how will institutions keep pace with demands for change at a time of economic pressures, including drastically reduced NIH budgets, lower reimbursements, and self-imposed cost-cutting measures? As one scientist says, they must innovate how they innovate. To help meet this challenge, Boston Children's Hospital launched SCAMPS, Standardized Clinical Assessment and Management Plans, an initiative to improve the quality of clinical decisions. Through efforts such as these, hospitals can increase efficiencies, decrease costs, and do a better job of tracking outcomes, resulting in more effective, affordable care for patients.
Let's start with the challenges, and I know we're going to talk about innovations that are occurring and how they can solve them, but let's start with the challenges, Dr. Altschuler.
For us to continue to support our missions the way that we have traditionally done and to advance pediatric health care, we have to change everything that we are currently doing. And that goes from the revenue model to education to the way that we fund research. We can start with education. When we get doctors and nurses who come to the hospital right now, they are completely unprepared to practice appropriate medicine in the way that is responsible, that is safe, and is high quality. So we have an education system that is completely out of touch with reality. What's interesting is that is every medical school, every institution that is involved in training practitioners of medical care. Second challenge, we have great scientists, we have individuals who do investigation, and they do it in a model that for the last 50 years has been the NIH, that has grown dramatically in the support that it is giving. Right now we are in the beginning of a cycle where we will see dramatic decreases in that funding. Basically, I think it puts the academic research enterprise at peril. Basically, as we bring people in for research training, we're going to have to train them how to be entrepreneurs. Entrepreneurial skills are going to be part and parcel of what we need in our fellowship-trained investigators. And then finally, the revenue model. We have to now find new revenue models specifically for pediatrics. And what do I mean by that? If you think about where pediatric health care is going, we will become a field that is ultimately involved in prevention of disease. Traditionally, prevention of disease has involved immunizations and other things, but if you think where prevention is going now, there are surgical techniques that can be done in utero that basically prevent disease and alter the natural history. You can use gene therapy to correct with one treatment single gene diseases now, and that will just expand. There's no revenue model that exists right now to pay for that. Those are areas that we have to tackle. What we're going to have to do is we're going to have to take the lead and really push those processes forward to get these issues solved, because people aren't going to do it for us. They'll actually probably fight us.
We are going to have to figure out how not to lose, whatever you want to call it, the secret sauce, the joy, the meaning of what we do, and preserve that while making changes that are dramatically different over time. And I think the changes will be accelerated by changes in medicine. Who we have in the hospital now doesn't even slightly resemble who used to be in the hospital 20 years ago. with the vaccines against rotavirus and influenza and other things. Medicine has changed. It's going to change dramatically more and dramatically quickly. It's going to be change in payment systems. There's going to need to be change in education systems. We are doing things now that we never thought about doing. Intellectual property is focusing really around a lot of things that aren't purely either device technology or product technology. They're about, ideas that are coming out. If you look at some of the work that's out there in the exhibits, like Open Pediatrics, in our relationships with IBM. If you look at the genomic work that we're doing by developing a for-profit Claritas, when we do things, we're going to have to think about partnerships. We can't do this alone.
Finances are going to be our number one challenge. Where do the resources come from? What's the reimbursement model? As we enter the world that Massachusetts has been living in, I guess, for a few years of the Affordable Care Act, what impact will that have specifically on children's hospitals? We have challenges today trying to figure out how to support the academic activities, the research activities, the things that catalyze innovation, and where are the resources going to come from in the future in an even more challenged environment to do that? Is philanthropy going to be enough? I tend to not think so. To some extent, we're probably, just to be somewhat provocative, we're probably going to have to prioritize or to decide, so where are the sort of the mega children's hospitals, the big children's hospitals, and who are the sort of, I don't want to say second class, but who are the lesser children's hospitals? Can you have 50 heart transplant programs? Can you have 3 bone marrow transplants in a state, transplant programs in a state? And who gets to decide? Will the government decide? Will we in our own enlightened self-interest decide? I mean, who's going to decide?
We all have IRBs, we all have clinical research support stuff, and we all biorepositories. So is there sort of a way to share resources, share strategy, since we're doing a lot of the same things, and where we can get some of those benefits? And the more provocative part of that question to you all is this going to be a trend towards mergers? Or is it not that dramatic a shift from a pediatric hospital perspective, and it's just really new modes of collaboration or business relationships among the hospitals?
There is opportunity for innovative collaborations both within the industry and with partners outside the industry. So one example that exists right now is through the Children's Hospital Association is a common GPO, I think, that has 38 children's hospitals. So they have a buying power of about $3 billion, and that can be used to help in terms of reducing cost. Same organization does provide the starts of an integrated database using administrative data that can be utilized to benchmark. So I think when you think about working together, yes, we want to think about healthcare. The only caution that I would say is that many of our neighbors in the children's hospital world may be very different even 5 years from now. So as one thinks about investing the time and effort in developing partnerships, one has to be very cognizant of what the future holds for a potential partner.
For us, at least, the focus over the last many years on trying to be the most efficacious, both in terms of cost efficiency and outcomes, is based on data. And any time that you deal with data, you need as large a database as possible. And for us, that has been very difficult. And I think a lot of this comes from the ground up. We have people in our institutions who are wonderfully committed to doing the right thing, but they don't know what the right thing is. And so how do you get them the information that they know of to do the right thing? And so we've got people, clinicians and data managers and other administrative people who are working desperately to try to develop the largest databases they can to figure out whether they're doing the right thing, and if they are doing the right thing, are they doing it in a cost-effective manner? I mean, that's what our job should be. And we can't do that alone. So we have to develop partnerships. The worst thing that we could do the thing that will stop innovation, this thing that will stop improvement, is where we use data to compete with each other. That's where we lose the game. And so all of this data should be submitted, should be analyzed, and it should be brought back for the use by the people on the ground so that we can do the right thing.
Dr. Gray, just a variation on that question. You had mentioned about the difference in resources among the different hospitals, and certainly among all of them, even the ones that have more resources than others right now, with sequestration, with other pressure on the financial pressure on the systems. I think a lot of people in the audience are concerned about, well, what does this mean in terms of the institutions supporting and investing in innovation? So one angle would say you need to double down on that investment now to create the innovations that are going to lead to cost savings, better outcomes, better tracking, all that. But is it a normal reaction of an institution to say, well, we've got to cut back on that right now?
You just described my daily life. I don't know that it's abnormal for the institution. I mean, the institution will do what it has to do to survive, and you can't spend what you don't have. But I feel like I'm sitting in front of a group of my physicians at the hospital. But that is the reality, and so either you create more resources or you figure out how to do it better, or more efficiently. And we go on gimbal walks every morning in our hospital, stopping at some 20 or so inpatient units, ambulatory clinics, environmental services, dietary, all over the hospital, and staff are engaged in identifying measures to make their operating unit better. It engages frontline staff, and they take some ownership, or a great deal of ownership, over what's going on in the hospital. And they understand the relationship of their unit to the siloed unit sitting someplace else in the hospital much better, because everything, of course, is interdependent.
There's a lot of examples now where hospitals are looking to expand their international strategy, not just even their local geographic footprint and strategy, but international. CHOP is a hospital that has been in the news or gotten some press with some of the things that it's done recently with some partnerships in China. Maybe you can talk a little bit about that and just how does this international or global strategy as it relates to pediatrics support the core mission, and then deal with some of the challenges that you guys are facing.
I went to visit China on one of our trips, and I'll tell you about the relationship in a minute, but it became very clear to me when I visited Beijing Children's Hospital, which is probably a facility that was built circa 1970, has 1,000 beds. And when you walk into the main lobby, be the lobby about the size of any of our institutions, literally there were hundreds of thousands of people in the lobby, and they told us that they were going to see 10,000 outpatients in the hospital. And their system was, you come at 7 a.m., the doors open, you take a number, and you just wait there till your number is called. So about this time, the Ministry of Health in China decided that they actually needed to create a private healthcare system. And so we've actually been working with a very interesting partner, the State Asset Management Company of the city of Beijing. We are currently in a management agreement to basically help them design, completely train their management team, their medical staff, install their IT in this new hospital, which will be a 400-bed women and children's hospital in the fifth ring of Beijing. For those of you who know, Beijing is a sprawling city of close to 30 million people. We will actually lend our brand to this facility. Traditionally, when people have done international medicine, it's really been with the primary desire has been to bring patients back to your home institution. This part is to really build internal competencies, and we're doing this in Saudi Arabia as well. There, the partner happens to be the Saudi National Guard. And to try to, again, create a revenue model where we can actually make money locally as well. Now, what I would tell you, and this was unexpected, as we've built competencies internally within companies, they actually send us more patients. So it's actually benefited that part of the program as well.
I was asked to do a more provocative question. This is to you all. Are you all competitors? Silence?
Yes. Yes.
The easy out with you. Yes.
I was just very cognizant that we were being videotaped. Children's Hospital of Michigan ain't a competitor with these two guys. But of course we are at some level, sure. But I think it's a very healthy and respectful competition. I don't see it as dysfunctional at all. I think it actually probably pushes each organization to be better. Certainly, every year when that bane of my existence, U.S. News and World Report comes out. So, Herman, how come? Oh, please. I think it's competition isn't all bad. I think it's a healthy competition. The competition I worry more about is the more local sort of competition where you get into the kind of the arms race kind of deal where not just the children's hospital that may be an hour or two away from you wants to do the same thing you do or does the same thing that you do, but the large adult hospital decides it wants to do the same thing that you do. And children's hospitals are unique community resources that are precious and extraordinarily important to the health and well-being of children in this country. While we number, there are 5,000 adult hospitals and 50 or so children's hospitals, we take care of a big chunk of the children with chronic and severe illnesses. These are institutions that need to be protected.
I think, as Herman alluded to, probably in the next 5 years, the greater competition is going to be coming from other aspects of the healthcare industry. We will face a number of very disruptive providers of care. We already are. Yep. So that, again, as children's hospitals, we have to be prepared to respond very, very quickly and to compete effectively on whatever the criteria is going to be.
We hear a lot of talk of providers becoming single-payer systems, especially in this world where we need to optimize both outcomes and costs. And I just wanted to get your viewpoints on that within your institutions. Is that a recipe for success? Not? What do you think? I
think if you do it, you have to go in with your eyes open. You have to figure out how you're going to be able to exist through those cycles of insurance. And I think you really have to be very careful on the capitalization and reserve issue because you can get yourself into big trouble.
Could you speak a little bit about the care delivery innovation in terms of taking therapies we know work, like for asthma care, and improving health equity for underserved populations? To what extent is that part of the mission? How do you balance that with new innovations in terms of new therapies? And how do you make the argument for that fiscally when frequently you're spending more resources to achieve outcomes that will be measured 30 years down the line?
One of the major issues, for us at least, is that innovation in terms of healthcare delivery and reducing costs and improving outcome is what we do every day. And so, the classic example that we talk about over and over again is the asthma program, where with the CDC's backing, we showed unequivocally that you could return about 1.5 for every dollar invested in a asthma program where your care was predominantly in the home. The problem is that the market is not even close to being aligned in providing reimbursements for those types of services, which clearly demonstrate over and over and over again a value that's beyond anything that we can show in just direct care.
I'm very worried about the next generation, and you're all inspirational leaders. You've created cultures here. How do you keep them excited, and how do you continue that culture of innovation?
There is no greater privilege than to get to know a family, a child, to intervene in some way, in a positive way that contributes to that child's well-being. People tell us their most intimate hopes, dreams, aspirations, fears, anxieties. We share something very, very special with other humans that no one else has. When there was nothing that medicine had to offer except, I will be there and hold your hand as your grandfather dies. If that was all we had, we were still the most respected members of our community, and we were viewed to be very powerful because of the interaction between one human being and another. It is an absolute privilege to be a physician. And I think we don't talk about that enough with our students and trainees. What you're doing is special, and it's more than intellectual. Sometimes imagination is far more important than knowledge. Sometimes commitment and passion is more important than technical skills. And your rewards come from the work.